Hello. Hello, good evening, guys. Hope you all are doing good. Okay, let's start this session. In this session, we'll be discussing about the frequently tested topics, mostly the trend that has been usually followed in the last 5 years of NEET PG is there are being questions coming on this 25 to 24 topics over here. Mallampatti, Cormac Lehan, RSI grading, RSI, ASA, NPO, Propofol. They are asking about the drugs. They are asking about the inhalational agents. They are asking about spinal and epidural, local anesthetic systemic toxicity, capnograph, ETCO2 interpretation, ARDS and ventilation, CPR, Bain circuit and monitoring. So what I have done is basically I have compiled all these topics in this session. So we'll be dealing with these topics based upon the MCQs. Okay. Right. So guys, we'll start with the first MCQ. A 64-year-old man with a history of COPD is brought to the emergency department with severe breathlessness. On examination, he is semi-conscious with a GCS of 9/15. His respiratory rate is also very high, which is 32, and saturation is 82 on non-rebreathing mask. ABG shows a pH of 7.2, PaCO2 of 76, and PaO2 of 52. So PaO2 is low, PaCO2 is high, likely to be in type 2 respiratory failure. But guys, remember what we can do over here. This patient, what is the next appropriate management, or what is the next appropriate step to be taken over here, guys? A, B, C, D are the options. Please write in the chat, guys. Good evening, good evening. What could be done over here? Now guys, over here, just look over here. The patient is in semi-conscious state with a GCS of 9/15. If GCS is low or semi-conscious, then remember the possibility of NIV is totally ruled out. What is NIV? Non-invasive ventilation, that is BiPAP or CPAP. You don't have to go for BiPAP or CPAP when a patient is semi-conscious state or in a drowsy state. Okay. So remember, neither you can go for starting a BiPAP, nor you can go for starting a CPAP over here. Why? Because his respiratory rate is very high. His PaCO2 is high. He will develop CO2 narcosis, and he might aspirate the contents, gastric contents, if you go for an NIV. NIV is always contraindicated if the patient is semi-conscious or unconscious. Okay. So now we are left out with what? Nebulized bronchodilators. You cannot go for nebulized bronchodilators when a patient is in respiratory distress. Immediately you go for endotracheal intubation with mechanical ventilation. So the answer over here is endotracheal intubation with mechanical ventilation. Guys, remember, ventilators, they are of two types, non-invasive and invasive. Non-invasive, the vital prerequisite is what? The main prerequisite is patient should be conscious. That is the main prerequisite for non-invasive ventilator. There are two modes in non-invasive ventilator, the CPAP and BiPAP. CPAP is continuous positive airway pressure, and BiPAP is it uses a higher inspiratory and a lower expiratory pressure. CPAP is usually used for mild to moderate COPD, and BiPAP is usually used for severe COPD cases. Okay. Now guys, next, a 56-year-old man is admitted in the ICU with severe pneumonia. He develops ARDS and he is intubated. The intensivist wants to use a lung protective ventilation strategy to reduce ventilator associated lung injury. Which of the following ventilator setting is most appropriate to be used in this patient? Come on guys, a patient is in ARDS. ARDS means already lungs are in a very bad state. If you overinflate the lung, what will happen, guys? If you overinflate the lung, then the prognosis will be more bad. Okay. So in ARDS, what is the strategy that we use? We use a low tidal volume, and in ARDS, usually there will be atelectasis. So you want a new alveoli to be recruited. That can be done with the help of PEEP, positive end expiratory pressure. So we usually go for a low tidal volume, high PEEP strategy. So remember guys, which is the lowest tidal volume which is given over here? I think in the option B, there is given low tidal volume with high PEEP strategy. Okay, high PEEP means what? 10 is not high, guys. You can extend the PEEP up till 24 also, depending upon the patient's oxygenation. Okay. Now guys, regarding ARDS, what we need to remember is, right. So regarding ARDS, we need to remember some of the ventilatory settings that we do, guys. Normally, remember, in any person, we keep a respiratory rate of how much? 12 to 18. But if the patient is having ARDS, depending upon how the patient's pH is, okay, we can increase the respiratory rate to 20 to 30 also in ARDS, 20 to 30 breaths per minute. Tidal volume, normally how much you keep, guys? 6 to 8 ml per kg. But in ARDS, you give 4 to 6 ml per kg. Low tidal volume. You don't want to overinflate the lungs. Already it's in a bad state. FiO2, how much you will keep? 21 to 100%. Remember, you start the FiO2 in ARDS, you start the FiO2 with a very high FiO2 of 100%, then slowly you reduce it. You don't want oxygen toxicity. Why? Because if you give more of FiO2, then more free radicals will be released, which can damage the lungs. So you start with FiO2 of 100 and you try to reduce it, or try to reduce the FiO2. Okay? PEEP you keep 5 to 24. Maximum up to 24 can be kept. And PEEP is nothing but what, guys? PEEP is nothing but positive end expiratory pressure. Okay? PrepLadder should be less than 25. Inspiratory to expiratory ratio, normally it is 1:2 or 1:3. But in the case of ARDS, we go for inverse ratio ventilation. We keep the inspiratory to expiratory ratio 3:1. Plus, you can also go for prone ventilation. Prone ventilation means keeping the patient in a prone position for 12 to 16 hours. Now guys, remember, if the patient is having a respiratory acidosis, you just increase the respiratory rate so that carbon dioxide gets washed off. So guys, remember, we are talking about what? ARDS. Okay? Now, regarding ARDS and ventilator, we have to remember, guys, not only for ARDS, we also need to remember something about the ventilatory modes that we commonly use in normal individuals who are having different pathologies. The patient is having different pathologies and now admitted to the ICU and he requires ventilatory support. If the patient is not at all breathing, guys, the first ventilatory mode that is commonly used for any patient, we are not talking about ARDS. In any patient, if the patient is not at all breathing, you go for CMV mode. In CMV mode is basically, I usually refer it as a machine mode. Machine takes the responsibility of the tidal volume as well as the pressure. Yani ki what is the machine? The ventilator. Ventilator is basically artificial lungs. If you are not able to breathe, ventilator will be breathing for you. But in CMV mode, it is the mode that takes responsibility of tidal volume and the pressure. But it requires the patient to be fully sedated. There should be no triggered breathing. So during CMV mode, there is no triggered breathing and the patient should be heavily sedated. But what is the side effect if you keep the patient on this mode for a long period of time, guys? The side effect would be patient becomes lazy. He depends upon this mode for a long time and he is not using his muscles for respiration. Due to that, he might develop atrophy of the muscles, atrophy of respiratory muscles, atrophy of respiratory muscles. Okay, that could be the side effect. Next is what, guys? If this patient is improving, I'll go for a step down mode. The step down mode is what? ACMV. In the ACMV, either you go for volume control or pressure control. The MCQ would be asking you, in volume control, what is the control variable? First of all, you need to understand volume control means what? I am setting a tidal volume. I set this tidal volume. In volume control, the control variable is what, guys? It is the tidal volume. Okay. And are you allowing the trigger breathing over here? Yes, some trigger breathing is allowed. It is a step down mode. Okay. You will allow the patient to have some trigger breathing. How is the sedation over here? Sedation is moderate. Okay. What is the side effect of this mode? Remember, guys, volume control mode is used when the patient is having normal lung mechanics. What does it mean, guys? Normal lung mechanics means the patient is on ventilator due to some other pathology. Patient might be having IC bleed, or patient might be having sepsis. Due to that, he is on ventilator. Not the pathology is not in the lungs. If the lungs are normal, you go for a volume control mode where you are setting the tidal volume. And what is the side effect of this volume control mode, guys? Remember, there are two side effects of this volume control mode. The first side effect that could be seen over here is what? Patient might be volume control, right? The side effect that you see with volume control mode is sometimes, guys, remember you are setting a tidal volume, right? And the patient during the course of the disease, he develops stiffening of the lungs. If he develops stiffening of the lungs, the main side effect could be what? Now remember, you are setting a volume, but he has developed a stiff lung. So what will happen now? The ventilator requires more pressure to inflate the lungs. So it will basically, remember, if you are setting a volume, ventilator will generate the pressure. Due to that high pressure generated from the ventilator, there will be a risk of barotrauma. There will be a risk of barotrauma. But sometimes if you have set the tidal volume low, if you have given a low tidal volume, there will be a risk of what? If you have set the tidal volume high, not low. Normally what happens is, sometimes you might set a tidal volume high. If there is high tidal volume set, then there is a risk of volume trauma. That is regarding in the volume control mode. Okay? Next, pressure is basically, remember, in volume control mode, pressure is generated by the ventilator. Next is pressure control mode. In the pressure control mode of ventilation, guys, remember, this is commonly used when the patient's lungs are stiff. In the patients who are having ARDS, primary pathologies in the lungs. In that, what is the control variable in pressure control? You are setting the pressure. Hence, it is the control variable is the pressure. Is trigger breathing allowed? Yes. How is the sedation given over here? Same, moderate, same like volume control. Okay? What is the side effect of pressure control ventilation, guys? Pressure control ventilation could be what? Remember, you are setting a pressure. Ventilator have to generate the volume. Sometimes, normally what happens over here is ventilator is not generating the volume that is required by the patient. Due to that, there is a risk of hypoventilation. And hypoventilation can lead to what, guys? Hypoventilation can lead to respiratory acidosis. Then there are spontaneous mode, the SIMV and the pressure support modes. SIMV and the pressure support, these are just the supporting mode of the supporting mode given to the patient when the patient is having adequate respiratory efforts. Okay, what are the side effect of this modes? The side effect of this mode is sometimes there might be a risk of hypoventilation. If the patient is not improving, there might be a risk of hypoventilation. Okay, so that's regarding what, guys? That's regarding the modes of ventilator. Next, yes, in SIMV and pressure support, there is a chances of asynchrony also. Next, guys, 24-year-old man with a significant past medical history is undergoing an elective open reduction internal fixation for femur under general anesthesia with sevoflurane and succinylcholine. After 20 minutes after induction, the anesthesiologist notices a rapid increase in EtCO2. Rapid increase in EtCO2 gives an alarm. Rapid increase in EtCO2 usually gives an alarm that there might be a case of malignant hyperthermia. With that, we'll just see what are the other things that justify the diagnosis. Patient is having tachycardia and generalized muscle rigidity. That is very, very important with rapidly increasing core temperature. That gives you a clinch of malignant hyperthermia. The earliest sign of malignant hyperthermia during anesthesia is what? A rapid rise in the EtCO2. And remember, what are the triggering factors that had triggered malignant hyperthermia in this case? Sevoflurane and succinylcholine. Almost all inhalational agents can cause malignant hyperthermia, and in muscle relaxant, it is succinylcholine that can cause malignant hyperthermia. So what is the next step to manage it? Remember, guys, the drug of choice is IV dantrolene sodium, but no one is asking the drug of choice. What are they asking first? The first thing is you have to stop the triggering factors and then give 100% of oxygen to the patient. Okay. Now, guys, regarding malignant hyperthermia, what are the triggers of malignant hyperthermia during anesthesia, guys? In local anesthetic, rarely there is a chance that lignocaine can cause malignant hyperthermia. All local anesthetic, they don't have any chance, lignocaine can cause. Okay? In muscle relaxant, it is choline that can cause malignant hyperthermia. Choline is nothing but succinylcholine. In inhalational agent, almost all, but maximum incidence is seen with halothane causing malignant hyperthermia. Safest are nitrous and xenon. They do not cause malignant hyperthermia. What is malignant hyperthermia? There is autosomal dominant mutation in what gene? RYR1 gene. Okay? Remember, due to this mutation, what is happening, guys? The abnormal ryanodine receptor gets triggered and it releases calcium. Due to the calcium release, there is muscle spasm which is starting from the masseter muscle, thereby whole body gets involved. Okay, how will you diagnose malignant hyperthermia? With a provocative test called as halothane caffeine test. But once malignant hyperthermia is diagnosed, stop the triggering factors and go for a drug of choice for malignant hyperthermia, which is IV dantrolene sodium. Very, very important. IV dantrolene sodium. Okay, what is the channel responsible in malignant hyperthermia? It is calcium channel. And what is the earliest sign of malignant hyperthermia during anesthesia? Rapid increase in EtCO2. Very, very important. Rapid increase in EtCO2. Next, guys. 42-year-old woman undergoes elective lap cholecystectomy under general anesthesia. Shortly after induction, she develops profound hypotension. Okay, bronchospasm and increased airway pressure and generalized erythema with tachycardia. What you are suspecting is anaphylaxis. Which of the following drug is most commonly responsible for perioperative anaphylaxis? So during surgery, what could be the thing that could cause anaphylaxis? Come on, guys. What's the answer for this? Propofol, ketamine, rocuronium, midazolam. Come on, which would have caused anaphylaxis? Anaphylaxis during surgery. Remember, anaphylaxis during surgery, the most commonly it is attributed to antibiotics. But if the question is asking you anaphylaxis during anesthesia, or what is the most common anesthetic cause of anaphylaxis, then your answer should be what, guys? Your answer should be muscle relaxant. Very, very, very important. Which muscle relaxant? Especially in muscle relaxant, you are having non-depolarizing and depolarizing. Depolarizing can also cause anaphylaxis. Non-depolarizing can also cause. But in non-depolarizing, which non-depolarizing can cause anaphylaxis more common? It is basically the benzyl isoquinoline. Benzyl isoquinoline that releases histamine and can cause anaphylaxis. So what's the answer over here, guys? The answer over here is propofol, ketamine, midazolam, rocuronium. Come on, what's the answer over here? The most common that can cause is rocuronium. Even though chances of anaphylaxis with rocuronium are rare, but still in the question they have asked you about anaphylaxis and they have given you anesthetic drugs, always go with a muscle relaxant that can cause anaphylaxis during surgery. So remember, guys, that's regarding the anaphylaxis. What are the other things that can cause anaphylaxis during surgery? It is, I told you, antibiotics is the most common. Next is muscle relaxant. Chlorhexidine anaphylaxis is rarely seen. Latex is seen. Apart from that, local anesthetics can also cause anaphylaxis. Which local anesthetics? Local anesthetics which are metabolized to PABA. PABA are para-amino benzoic acid. So can anyone tell what are the two local anesthetics that can cause anaphylaxis during surgery? Come on. Come on, bolo bhai. What are the two local anesthetics that can cause anaphylaxis during surgery? Very good. The local anesthetics which are metabolized to PABA, P and B, local anesthetics starting with P and B, amino ester starting with P and B, procaine and benzocaine. Procaine and benzocaine can cause anaphylaxis. Okay. Next, guys. A 28-year-old man is scheduled for emergency laparotomy under general anesthesia after induction with IV anesthetic agents and a neuromuscular blocking agent. Direct laryngoscopy is attempted, but endotracheal intubation fails. During insertion of the following device, if still the patient cannot be ventilated, then there is worsening of saturation. What is this device insertion? Just look over here, guys. What has been inserted in the patient's mouth? LMA. So basically he is asking if intubation fails, and this device is what? Nothing but LMA, laryngeal mask airway. In that I am using iGel. Okay. So if this also fails in ventilating the patient, what is the next step? Come on, guys. What's the next step? Very good. Most of you are giving the wrong answer. That is A. Okay. A is the wrong answer. I'll tell you what is the reason. Remember, those guidelines has to be in your mind. Okay? Remember, in those guidelines, what is the first step? You go for intubation. Intubation failed. Over here, I have already told you intubation has failed. If intubation has failed, go for the next step. What is the next step in those guidelines? LMA insertion. I was putting in LMA. Still, I am not able to ventilate. If LMA also fails, I'll go for 3. I won't jump for the 4th one. Okay, those guidelines A, B, C, D or 1, 2, 3, 4 you have to remember. First is perfect intubation attempt. If failed, you go for LMA. If LMA insertion failed, then you go for what? 2% technique of ventilation. 2% technique of ventilation. If this also fails, then you have to declare it as CICV. Cannot intubate, cannot ventilate. Then you can go for what? Scalpel cricothyrotomy, then convert into tracheostomy. Okay. So remember guys, re-intubation cannot be done, reinsertion cannot be done. 2% technique of ventilation. As I have already told you, the plan A is what? You guess, give your best attempt for intubation. Plan B is you insert the LMA. Plan C is if LMA fails, you go for 2% technique. If plan C also fails, then you go for what guys? Then you go for scalpel cricothyrotomy, and then you can go for. But sir, 3 times we can try to re-intubate. I read the question once again. Intubation attempt has been done over here. They have been, I think they have done 3 attempts. Okay. After 3 attempts only they go for LMA. ऐसा नहीं है कि after 1 intubation attempt you put an LMA, then you remove it and then you go for another intubation attempt. No. Okay. So now guys, remember, as we are talking about what? Cricothyrotomy. Remember cricothyrotomy or tracheostomy. In that tracheostomy tube, guys, you remember tracheostomy tube? What is the function of tracheostomy tube? There have been questions on function of tracheostomy tube. It is basically used for mechanical ventilation. If there is any secretions in the trachea or in the lungs, you can easily do suction. It can be used for pulmonary toileting also, right? And remember, it bypasses any upper airway obstruction. This is the function of the tracheostomy tube. This tracheostomy tube comes with a cuff, which is similar to the cuff of endotracheal tube. It provides a seal and prevents aspiration risk. This cuff. Okay. Next, 58-year-old man achieves return of spontaneous circulation after ventricular fibrillation and cardiac arrest. Sir, same question. Third under senior consultant. देखो भाई, senior consultant, or if you want to call senior consultant, first your intubation attempt fails, then only you should tell, I feel it difficult, then only call for it. Okay. After you try for 3 attempts of intubation, already saturation has gone low. You have to ventilate the patient with the help of laryngeal mask airway. Okay, once the laryngeal mask airway is done and all, then at that time, then you and your consultant who came, you can discuss whether we go for re-intubation, whether you go for whether you can continue the surgery with the LMA and all. Okay, so over here, he remains unconscious. Okay, 58-year-old man achieves return of spontaneous circulation after ventricular fibrillation cardiac arrest. He remains unconscious and is intubated. Which is the most appropriate next step in his management? Come on guys, A, B, C, D. Once the patient has achieved ROSC, will you immediately extubate the patient? Never. I wouldn't extubate the patient. Okay? Will you administer thrombolytics routinely? Why to administer thrombolytics? If he developed ventricular fibrillation cardiac arrest and he's also having IC bleed, then if you give thrombolysis, then you're worsening it. So directly don't jump for thrombolysis unless and until it is indicated on the ECG. Okay, ECG is showing changes cardiac from the cardiac side. Someone is telling you. Okay, wait until the patient regains consciousness. That is also not done. The best thing is what? Once the patient regains consciousness, you have to start the immediate post cardiac arrest care, which includes hemodynamic optimization. In that, MAP should be how much, guys? MAP should be more than 65. That should be your aim. You can achieve this MAP by giving IV fluids or inotropes. Systolic BP should be more than 90. That should be your aim. Okay. And the saturation should be how much, guys? Saturation should be between 92 to 98%. And PCO2 should be 35 to 45. That should be your aim. Now, keeping the saturation over here means you have to check for the airway patency. But the most important thing over here is you go for target temperature monitoring, where you are keeping the patient's body temperature to 32 to 36 degrees Celsius. That is very, very important. That basically reduces the cerebral metabolic rate. That basically, if you are reducing the cerebral metabolic rate, the oxygen consumption by the brain can be reduced. Okay, so that is very important over here. Now guys, remember, we also have to remember We also need to remember, yes, saturation between 94 to 98%. If the saturation increases by 98%, don't tell that we can't keep. 92 to 94 to 98, it is optimum. So guys, remember some of the things we also need to remember is about the CPR. Now remember, if a person suddenly collapses anywhere, the first step that you do is you activate the SCCS system. What is this SCCS system? It is basically the sequence of the BLS. Sequence of BLS is what? SCCS. S stands for what? First, scene safety. Second is what? You check for the response. If the patient is not responding, SCCS. Okay? If the patient is not responding, you call for help, and then you check for the pulse and breathing. Which pulse you choose in adults? Usually you go for carotid pulse, and in infants you go for brachial pulse. You check for the brachial pulse, and remember, pulse and breathing should be checked simultaneously. If there is no pulse, no breathing, you start your CPR. What is the steps or what are the components of CPR? Before we used to use ABC protocol, airway, breathing, circulation, यही पढ़े थे. But अभी हमें याद रखना है कि nowadays we are using a CAB protocol. We are starting with compression, then airway, and then breathing. Now regarding this, remember guys, how many compressions you are giving in a minute? In a minute you need to give 100 to 120 compressions. That is very, very important. What is the depth of compression? 2 to 2.4 inches or 5 to 6 centimeters. 5 to 6 centimeters in an adult. If it is an infant, 1.5 inches or 4 centimeters. If it is a child, then you have to, child यानी कि more than 1 year, then 2 inches or 5 centimeters or 1/3 of the anterior posterior diameter of the patient's chest. And what should be the ratio, guys? 30:2. In a minute, you need to give 4 sets of 30:2. After completing your compressions, you need to open the airway. In any normal person, you open the airway with the help of head tilt and chin lift. Head tilt and chin lift. Whereas in the case where you are suspecting any neck injury, how will you open the airway in neck injury or any fracture? You open the airway with the help of jaw thrust. That is also very important. Okay. Now guys, regarding the compression to ventilation ratio, if it is a single rescuer, 30:2 compression to ventilation ratio. If it is more than one rescuer, still 30:2 in adults. In adults, always 30:2. Whereas in pediatrics, if you are a single rescuer, 30:2. If there are more than one rescuer, then you have to go for 15:2 ratio. But if at all your friend has already intubated or your friend has put an LMA, then don't do 30 compression and stop and give rescue breaths. No. If your friend has put an LMA or any advanced airway device, every 6 seconds you have to ventilate the patient. Okay, every 6 seconds, one rescue breaths every 6 seconds, यानी कि 10 rescue breaths per minute should be given in adults. Whereas in the case of pediatrics, 20 to 30 rescue breaths, यानी कि every 2 to 3 seconds you are giving one rescue breath. In case of newborns, compression to ventilation ratio is 3:1. Okay. Next guys, remember one more thing regarding the CPR and all. There have been questions asking about unstable tachycardia. Patient is in ICU having a tachycardia very high. How will you manage? Remember guys, patient having a heart rate of 170 beats per minute, he is in ICU. If you want to manage this, first you have to know whether it is stable or unstable tachycardia. How will you come to know the patient is having unstable tachycardia? You look for the signs of instability. What are the signs of instability? Signs of instability are Hasia signs. What are Hasia signs, guys? Hasia means hypotension. A stands for altered mental status. Okay. S stands for signs of shock. I stands for ischemic chest discomfort. It's not intercostal drain. Ischemic, and A stands for acute heart failure. If the patient is having any of these signs, the immediate management should be what, guys? You have to go for synchronized cardioversion. That is very, very important. Very important in the management of what? In the management of unstable tachycardia. But if the patient is having a stable tachycardia, then you have to go for what? Vagal maneuver. Nowadays it is not done, but still we have to remember, in the book still it is written. So in case of stable tachycardia, vagal maneuver is done, VABC is done, vagal maneuver, adenosine is done, and beta blockers as well as calcium channel blockers could be done. Okay. If the patient, remember guys, when is this position given? When is this position? This position is called as recovery position. Recovery position. And this recovery position is given in which patients? In patients who are having what, guys? If there is pulse, if there is breathing, but there is no response, then you go for recovery position. Very, very important. Pulse present, breathing present, no response, you go for recovery position. Next, guys, identify the pointed mark which is given in the picture. Come on, guys, what is the pointed mark given in the picture? Which is a pointed mark? First of all, what is the first shown? This is regarding the pulse rate as well as the ECG. Okay? This is regarding the SpO2 wave. This is regarding the EtCO2. So remember, guys, this is regarding what? Capnography. So during anesthesia, you're monitoring the patient's oxygenation. How will you monitor the patient's oxygenation? With the help of pulse oximetry, which usually works on Beer-Lambert's law. Ventilation, how will you monitor? With the help of capnography. Okay? Circulation, how will you monitor? Circulation is monitored by BP, ECG, and transesophageal echocardiography. In the BP, you are having invasive blood pressure monitoring where you are using which artery, guys? Radial artery. Okay? How will you know the patency of the radial artery? With the help of a test which is called as Allen's test. Okay? Allen's test can be done. Okay, next is what, guys? ECG. In ECG, lead 2 and lead 5. Lead 2 detects arrhythmias. Lead 5 detects ischemia. Next, temperature. In temperature, guys, what are the things that you are monitoring for? In temperature, you are monitoring for the core temperature and peripheral temperature. What is the common site for using core temperature monitoring? Commonly used site for core temperature monitoring is esophagus. But most accurate is what? Pulmonary artery. But pulmonary artery, as it is being invasive, we are not using that commonly. We are using esophagus. Apart from that, we also monitor for the patient's awareness. How will you come to know the patient is aware or not? With the help of bispectral index, which calculates the sum of EEGs, which calculates the sum of electroencephalograph. Next, you look for the neuromuscular monitoring. What is the nerve involved in neuromuscular monitoring? Remember, in neuromuscular monitoring, we are having many monitors. The commonly used is train of 4 monitor. In train of 4, what is the commonly used nerve, guys? It is the ulnar nerve, and the muscle commonly used, it is the adductor pollicis. Very, very important. Adductor pollicis. In train of 4, again, they will be asking you about the ratio. Train of 4 ratio, when you're using a depolarizing muscle relaxant. In depolarizing muscle relaxant, all twitch heights are decreased in the equal intensity. The ratio will be 1. In non-depolarizing, the ratio will be always less than 0.4 and you will see a fade. Fade is seen. In reversing, if the patient if surgery is done and if you want to reverse, then the ratio should be more than 0.9. Okay. We have discussed train of 4 ratio in the LRR and the RR. You can just go through it and get it. Okay. Next, a patient undergoes endotracheal intubation. Immediately post intubation, auscultation is done. Breath sounds are heard on the right side of the chest, while left hemithorax there is no breath sounds. With stable vitals, what is the most likely explanation for this? Come on, guys. What's the most likely explanation for this? A, B, C, D. Come on. I have intubated the patient. If at all after intubation, if my tube was in the mid of the trachea, then I would have seen breath sounds in the right as well as left lung equally. But if at all he's telling what only in the right side, that means you have put the tube or you have advanced the tube into the right bronchus. That's why you are only able to see the right, you are able to hear the breath sounds only in the right hemithorax. So the answer over here is what, guys? Right main stem bronchial intubation. If it was esophageal intubation, no breath sounds, neither on the right, neither on the left. If it is a bilateral bronchospasm, you will still feel breath sounds which are very much reduced, and with that you will see wheeze also. If it is normal midtracheal intubation, you will see breath sounds on the bilateral sides. Okay. Now, guys, remember, how will you come to know that you have intubated the patient properly, yani you are in the trachea, yani what is the best test to confirm intubation? It is always capnography. The best way to confirm intubation is the capnography. Very, very important, guys. In the capnography, there are 4 phases. Very, very important. What are the 4 phases in capnograph? Phase 1, 2, 3, and 0. Phase 1 is called as inspiratory baseline. Phase 2 is called as expiratory upstroke. Phase 3 is called as alveolar plateau. Very, very important. Alveolar plateau. And phase 0 is called as inspiratory downstroke. Inspiratory downstroke. Now guys, look over here. Between phase 2 and phase 3, there is an angle called as alpha. Phase 3 and phase 0, there is an angle called as beta. ETCO2 is measured at this angle. Very, very important. ETCO2 is measured at this angle called as beta. Now guys, remember what are the different forms of ETCO2? They have been asked many times. Now, if after intubation, normally you have to see, remember guys, first of all, you need to understand this. After intubation, normally you have to see this kind of capnograph. This is normal. But after intubation, if you see a flat capnograph like this, what does it indicate? A flat line indicates you are in the esophagus, esophageal intubation, or sometimes you might be in the trachea, you might see a flat line. Yani ki after intubation, patient develops cardiac arrest, you will see a flat line. Or sometimes after intubation, you are in the trachea but still flat line. It might occur when there is a complete bronchospasm. Complete bronchospasm. I have written the common causes, guys. Okay. If you see a sudden ETCO2 that is falling, that is usually indicating venous air embolism and all. That we'll discuss later. Next, guys, shark fin capnography. Just look over here, guys. If you are seeing a shark fin capnography, the capnograph appears like a fin, shark fin. What does it indicate? The patient is having bronchospasm. I'm not talking about complete bronchospasm, just bronchospasm. Initially, it is usually low, but then ETCO2 rises. Next, if you see after intubation, if you see the capnograph like this, it was appearing normal. Slowly it is increasing. Step ladder increase in the capnograph. What does it indicate? Guys, you can see the capnograph value is increasing. That indicates the patient developed malignant hyperthermia. In case of malignant hyperthermia, you will see a step ladder increase in the capnography. Sometimes after intubation, you might see capnograph not starting from this level. It is starting above the baseline. If the capnograph is starting above the baseline, what does it indicate? Remember guys, in anesthesia, we use a circuit called as closed circuit where there is no expiratory valve. So what happens? The carbon dioxide which is exhaled by the patient goes into the soda lime chamber and gets absorbed. But if that soda lime which is absorbing carbon dioxide, that is only exhausted, then what will happen to the capnograph? Capnograph usually starts above the baseline. So you will see capnograph starting above the baseline in which condition? If soda lime gets exhausted, soda lime exhausted, or there is any problem in the expiratory valve. Expiratory valve, if it is faulty, soda lime exhaustion and expiratory valve faulty, you will see this capnograph. Okay? If you are seeing a capnograph like this, guys, sudden fall in the ETCO2, sudden fall in the ETCO2, and a reverse step ladder. So what you need to remember? Venous air embolism. Venous air embolism, the most common murmur that you see is mill-wheel murmur. Okay. If you see a Currar notch developing in the capnograph, come on guys, please answer this. If you see a notch developing in the capnograph, what does it mean? And what is your next step? Come on, be fast. If you see a Currar notch, what does it mean, guys? That means there is return of spontaneous ventilation, not circulation. Return of spontaneous ventilation. Patient who was on under the muscle relaxant effect, now the muscle relaxant effect is gone and patient is breathing spontaneously. So what is the next step? Next, you have to give the top-up dose of muscle relaxant. Top-up dose of muscle relaxant. That is the management. Okay. That's regarding what, guys? That's regarding this. Okay. In case you increase the respiratory rate, the carbon dioxide gets washed off and you see a capnograph like this. Capnograph value low, and you will see in hyperventilation, you will see this capnograph. In case of hypoventilation, if you decrease the respiratory rate, then what you will see? the carbon dioxide is increased like this. Okay, in case of hypoventilation, carbon dioxide rises. Okay, and you will see this capnograph. Next, a 30-year-old man is admitted with suspected meningitis and lumbar puncture is performed at L3 L4 space to obtain cerebrospinal fluid, this which is the last anatomical layer pierced by the spinal needle before it enters the lumbar cisterna. Whether you are taking the cerebrospinal fluid for diagnostic purpose or whether you are performing a spinal anesthesia, the question remains same. Whether cerebrospinal fluid analysis. What is the last layer pierced by your needle before entering the subarachnoid space or lumbar cisterna? Come on, guys. What's the answer over here? Dura, ligamentum flavum, supraspinous ligament, or arachnoid. Guys, remember, if anyone asks you this silly question, you tell them. Some say spinal instigates lethargy during anesthesia. Okay? Some say spinal instigates lethargy during anesthesia. Everyone look over here. Thing is written over here. Just look over here. If I am passing my spinal needle, first layer will be skin, next subcutaneous tissue, next supraspinous ligament, next interspinous ligament, next. Just look over here. Look at this movement now. Ligamentum flavum. Once you puncture ligamentum flavum, you will come to know that you have pierced it. Why? Because ligamentum flavum is the toughest ligament. Very, very important. Ligamentum flavum is the toughest ligament. On piercing of ligamentum flavum, you will feel a sudden loss of resistance or a snap or a pop. Remember, during spinal anesthesia or lumbar puncture, you will feel two snaps. First pop you will feel, or first snap at piercing of ligamentum flavum. Second pop you will feel on piercing of dura. Once you puncture the dura, you will be in arachnoid. Once you puncture arachnoid is the last layer, guys. Okay? Once you puncture the arachnoid, you will be in the subarachnoid space that has the CSF. It's not that subarachnoid is the last layer. Arachnoid is the last layer to be punctured in spinal anesthesia. Now, guys, remember, once you are giving spinal anesthesia, before giving spinal anesthesia, make yourself ready to face the complications of spinal. What are the intraoperative complications of spinal, guys? Intraop complication, the most common is what? It is hypotension. And this hypotension can be easily managed with the help of phenylephrine. Okay. Next common complication is bradycardia, that could be managed with atropine. Next is shivering. The patient might have shivering. Remember, guys, spinal usually produces sympathetic blockade of the lower extremities. Due to that only these complications are happening. Shivering management, what should be given? Pethidine should be given. Sometimes you have given spinal anesthesia. You wanted your drug to act till the level of xiphoid sternum, but your drug reaches till the level of nipples. Yani ke you wanted, your desired level was xiphoid sternum, but you have achieved what? Nipples. Yani ki when your achieved level is higher than the desired level, it is called as high spinal. High spinal is characterized by two things together, hypo and brady together. So I am not worried about these complications. Why? Because I am preparing an emergency drug tray where I am keeping phenylephrine, atropine, pethidine ready with me. Okay. What are the post-op complications of spinal anesthesia, guys? After operation, the most common post-op complication that patient might have is urinary retention. But nowadays it is not seen. Why? Because usually patient who's posted for spinal anesthesia, I am putting a Foley's catheter so that they don't develop this complication. Okay. Next, headache can occur, but nowadays it is not seen, guys. Headache is also seen if you are using a dura cutting needle. If you are using a dura separating needle, no chance of headache. But usually it is common. This headache is common. This headache is called as, if headache is developing after spinal, it is called as post-dural puncture headache. It is commonly seen in young individuals who are usually exposed to multiple surgeries like cesarean section. Okay. If at all the patient develops headache due to the puncture in the dura, what is the best management? A conservative line of management where you are giving the patient coffee, NSAIDs, and rest to the patient. The definitive management is what? Epidural blood patch. Where you are taking the patient's blood and injecting through the epidural needle into the space where you have given spinal anesthesia. That forms a clot and closes the dura. Okay. And third, what is the nerve that could be damaged? Sixth cranial nerve, as it is having a long course. Next, Epidural anesthesia. Just a brief of epidural. Epidural anesthesia, they might ask you about the needle. What is the needle used in epidural anesthesia? The needle that we use in epidural anesthesia is 2-Houys needle. Very, very important. 18 gauge 2-Houys needle commonly used. 16 gauge can also be used. Epidural is used for below umbilicus long duration surgeries. Remember, spinal is also used for below umbilicus short duration surgeries. Okay, epidural can also be used for many other reasons. If you are placing a cervical epidural, it is commonly used for neck pain or neck radiculopathies or lymph node dissection. Thoracic epidural can also be placed depending. Remember guys, epidural placement totally depends upon for what purpose are you using. Okay, if the patient is having rib fracture and you want to reduce the pain, you can place a thoracic epidural. And for thoracotomy pain also, you can use thoracic epidural. Lumbar epidural is used for below umbilicus long duration surgeries, as well as for labor analgesia. Labor analgesia means painless labor. Next. 65-year-old patient with severe hypoxemia is admitted to the emergency department. The physician wants to improve the highest possible oxygen concentration using a conventional oxygen delivery device. Which device is most appropriate? Come on guys, what's the answer for this? Nasal prawns, simple face mask, venturi mask, or non-rebreathing? Come on, what's the answer for this? In conventional oxygen delivery device, if you want to deliver a highest concentration of oxygen, what you will use? Nasal prawns will deliver 25 to 45%. Simple face mask 35 to 65%. Non-rebreathing will deliver 95%. In conventional, it is the highest. So these are the oxygen delivery devices, guys. The first we use is simple. We use a nasal cannula. If saturation is not improving, we go for face mask. If still not improving, NRBM. Then venturi or high flow nasal cannula. Normally, if NRBM is not working, directly you go for high flow nasal cannula. Now, guys, remember. For remembrance, you have to remember in this sequence. What is the flow rate and what is the FiO2 delivered? So look over here, guys. The answer over here is NRBM. Regarding nasal cannula, the flow rate is 1 to 6 liters, which delivers an FiO2 of 25 to 45%. With face mask, you can deliver 6 to 10 liters of oxygen. That delivers an FiO2 of 35 to 65%. With NRBM, you can deliver 10 to 15 liters of oxygen. That delivers an FiO2 of 95%. Venturi mask, 2 to 15 liters of flow rate you can keep. That delivers an FiO2 of 24 to 60%. But it is fixed. It is not variable. Nasal cannula, face mask, NRBM, these are variable performance devices. Venturi mask and high flow are fixed performance devices. Okay? Venturi mask usually works on a principle which is called as Bernoulli's principle. Okay, high flow nasal cannula, which can deliver how much of oxygen, guys? 40 to 60 liters, which delivers 100% of FiO2. High flow nasal cannula. Okay, that's regarding the oxygen delivery device. Remember, guys, you don't have to wait. If the patient's oxygen saturation is going below 90%, then you need to remember this point that tissues become vulnerable to hypoxia below 90%. You have to start any oxygen delivery device because below 90% tissues become vulnerable to hypoxia. Next. The shown device belongs to which category? First of all, what is this device, guys? This device is a supraglottic airway, or it is called as laryngeal mask airway. Now, this belongs to which generation? First, second, third, or special type of intubating LMA? What is this, guys? If I see two openings, immediate answer is what? It is a second generation LMA. It is a ProSeal LMA. So remember, guys, in LMA, is it a definitive airway? It is a non-definitive airway. Why it is non-definitive? Why? Because it cannot prevent aspiration. It can cause aspiration. Okay. In LMA, one port LMAs comes under first generation, such as classical LMA, flexometallic LMA, Cobra LMA, and Ambu Aura 40 LMA. These are first generation. Second generation means two ports are there, one tracheal and one esophageal. If at all the patient is full stomach also, through the esophageal port, you can put the Ryle's tube and deflate the stomach. Okay? LMA ProSeal, LMA Supreme, iGel is there, Ambu Gain is there, and Slip-I is there. Streamliner of pharynx. These are second generation LMA. So the answer over here we have already discussed. Next, A 3-year-old child is scheduled for a short surgical procedure under general anesthesia. The anesthesiologist plans to use a breathing system that can effectively support controlled ventilation during anesthesia while also supporting the spontaneous ventilation. Which of the following circuit should be used? 3-year-old child, which circuit should be used? Which should be effective for controlled as well as spontaneous? First of all, guys, before going for the answer, just look over here. The mnemonic to remember the breathing circuits are SACD. For spontaneous ventilation, circuit A. For controlled ventilation, circuit D. But the answer, the question over here is what? 3-year-old for pediatric, and he is asking spontaneous as well as controlled. Always remember the circuit of choice in pediatrics is Mapleson F circuit. Very good. Mapleson F circuit in pediatrics. Mapleson A. We are discussing something about the breathing circuits. Mapleson A is also called as Maggle circuit. This is a circuit of choice for what ventilation? This is a circuit of choice for spontaneous ventilation, where you have to keep, in order to minimize the rebreathing, you have to keep the fresh gas flow, which should be equal to minute volume. Next, B and C are not used. Then it's Mapleson D. Mapleson D is also called as Bain circuit. Okay, R is silent. Bain circuit. Bain circuit is a circuit of choice for what ventilation? Controlled ventilation. In order to prevent the rebreathing, we use a fresh gas flow 1.6 times the minute volume. Mapleson E circuit is basically what, guys? It is not used nowadays. It is also called as Ayers TPs. And this E circuit was modified by a guy called as Jackson Rees. Hence, that modification of type E circuit was a bagless circuit. They added a bag to type E circuit. Who added? Jackson Rees. That's why type F circuit is called as Jackson Rees modification, which is a circuit of choice for pediatric for spontaneous as well as controlled ventilation. Spontaneous as well as controlled ventilation. Okay. ठीक है, राइट. हाँ बोला ना, fresh gas flow 1.6 times a minute volume in case of control. We have discussed that. ठीक है. Next, closed circuit. If you are using closed circuit, remember guys, semi-closed circuit we are having valve. In closed circuit, there is no valve that allows expiration. All expired gases in the closed circuit goes into this chamber, which usually absorbs the carbon dioxide. What does this chamber usually have? Soda lime. Remember guys, soda lime is made up of what? 80% of calcium hydroxide. Yani कि major component of soda lime is calcium hydroxide. Next, 16% water and sodium hydroxide 3%. That is the main component. 1 to 2% it is made up of silica. Silica is added to improve the hardness of the granules. Improve the hardness of soda lime granules. Okay. There are some inhalational agents which are usually avoided with soda lime. What are the inhalational agents which usually avoided with soda lime, guys? CT scan. C stands for chloroform. T stands for trilene. S stands for sevoflurane. Sevoflurane, if you add with soda lime, it forms a compound called as compound A or olefin, which is a nephrotoxic compound. Okay. Next, guys. 45-year-old patient undergoes elective abdominal surgery under general anesthesia. Muscle relaxant is given such as rocuronium. Okay, rocuronium, whenever anyone tells me rocuronium, I'll write RO of rocuronium. That gives me that it is a rapid, it is having rapid onset. Yani कि it is a fast acting drug, fast acting muscle relaxant, fast acting muscle relaxant. Anyways, at the end of surgery, the anesthesiologist wants to rapidly and safely reverse the neuromuscular block. Which of the following drug is most appropriate for reversal of rocuronium-induced neuromuscular blockade? For rocuronium-induced muscle blockade, what can be given? Neostigmine, atropine, naloxone. Naloxone and atropine I directly rule out. Why? Because atropine is not used as a muscle reversal. Atropine is used with neostigmine, but it is not used. Now we are left out with neostigmine and Sugamadex. I can use both for the reversal. But if I am having the best, why should I use the, why shouldn't I use it? So the best is what? Sugamadex. It's a modified gamma cyclodextrin, which is commonly used against rocuronium and vecuronium. Sugamadex. But remember, neostigmine can also be used. But if you give neostigmine, there is a risk of bradycardia. So what we are doing nowadays is, with neostigmine, you either add glycopyrrolate or either add atropine and give to the patient. Okay? So remember the answer over here is what? Sugammadex. In the reversal agent, I have already told you neostigmine, pyridostigmine, L-cysteine, hydrophonium is there. Neostigmine, never give plain. Most commonly we are giving neostigmine. Neostigmine with either glyco or either atropine you have to give. Okay. And I told you Sugammadex is used for rock and vecuronium. Right. Next. 40-year-old man undergoes an intercostal nerve block with bupivacaine. Shortly after injection, he develops tinnitus, circumoral numbness, hypotension, and ventricular tachycardia. Which of the following best explains the therapeutic action of cardiotoxicity of bupivacaine? Guys, remember here they have given a classical case of local anesthetic systemic toxicity. They were trying to give intercostal nerve block, but it has they are trying to give intercostal nerve block, and as they are introducing the needle, they are there is a high blood supply. So what will happen, guys? If the bupivacaine goes intravascular, there will be chances of toxicity. So he is asking you ABCD. Local anesthetic systemic toxicity usually occurs by acting on what channels? By acting on what channels, guys? It usually occurs, it does not act on the potassium channels, neither the calcium, neither there is inhibition of acetylcholine. There is blockade of voltage gated sodium channels. Very, very important. Local anesthetic also normally acts through this mechanism only. Okay. Now, guys, regarding local anesthetics, you have to remember a few things, guys. Longest to shortest acting local anesthetic, if you remember, you can remember most points of the local anesthetic. Longest to shortest local anesthetic, the mnemonic is Delhi to Bombay loves PC. D stands for what? Dibucaine is the longest acting local anesthetic, but it is the most toxic. We are not using. T stands for tetracaine, shorter than dibucaine. B stands for bupivacaine. Regarding bupivacaine, what we need to remember, mere bhai, bupivacaine is the most cardiotoxic local anesthetic. Okay? L stands for lignocaine. Lignocaine is a local anesthetic which is commonly used worldwide. P stands for procaine. Okay? C stands for, remember, procaine is the safest in malignant hyperthermia, and the shortest is what? Shortest is chloroprocaine. Chloroprocaine is regarded as the shortest acting local anesthetic. Now, regarding lignocaine, there have been some questions, guys. Regarding lignocaine, what we need to remember is, just look over here. Regarding lignocaine, L stands for, with the L of lignocaine, you can remember, lignocaine is the most commonly used local anesthetic worldwide. Most commonly used local anesthetic worldwide. ठीक है? I of lignocaine से क्या याद रखेंगे? Lignocaine is commonly used in IVRA. IVRA is nothing but intravenous regional anesthesia. And with the G of lignocaine, you have to remember lignocaine produces garmi. Rarely it produces garmi, but which garmi? It produces hyperthermia. Which hyperthermia, guys? Malignant hyperthermia. Malignant hyperthermia. Even though rare, but it can produce malignant hyperthermia. Okay? Right? Local anesthetic which is having a vasoconstrictive effect. Normally all local anesthetic will cause vasodilation, but local anesthetic having vasoconstrictive effect is cocaine. Cocaine will produce vasoconstriction. What is garmi, guys? Garmi means basically it's a Hindi term for high temperature. Okay. Next. 68-year-old man with severe aortic stenosis is scheduled for emergency cardiac surgery because of his unstable hemodynamics. Anesthesia is induced with ethomidate. Obviously, if the patient is having aortic stenosis and you don't want his BP or heart rate neither to fall nor to raise, then you have to go for ethomidate. Why? Because ethomidate is a cardiostable, maintains the BP and pulse rate. 12 hours after the surgery, he develops persistent hypotension despite of fluid resuscitation. Lab suggests cortisol production. What is the best explanation for mechanism of this complication? Remember, guys, ethomidate is the most cardiostable IV induction agent, but at the same time, you also need to remember when you give ethomidate, there are some chances that the patient might have inhibition of 11 beta hydroxylase enzyme that can cause adrenal suppression. So the answer over here is B, adrenal suppression. Now, regarding the IV induction agents, we need to remember few points of few IV induction agents, guys. That is very, very important. So remember, IV induction agents are the agents which are used to make the patient unconscious. In that, you are having non-opioid and opioid. In non-opioid, you are having thiopentone, propofol, and ethomidate, which usually acts through the GABA A chloride channel, and basically they are blocking the GABA channels, whereas ketamine usually acts on the NMDA receptors. That is important, guys. Ketamine. Apart from ketamine, xenon and nitrous also acts on the NMDA receptor. But if the patient is having a low ejection fraction, instead of going for a non-opioid induction, you go for a opioid induction. Apart from these non-opioid, you can induce the patient in the non-opioid, you can induce the patient with benzodiazepines also. But always keep ready with an antidote. What is the antidote of benzodiazepines? What is an antidote of benzodiazepine? Please, guys, just write in the chat box. Yes, it will be helpful for all exams. Okay. What is the antidote for benzodiazepine? Please write in the chat box. Bhai, very good, very good. Flumazanil. Very good. Chalo. So ethamidate is the most cardiostable, but long-term infusion of ethamidate can cause adrenal suppression. Apart from that, there is methotrexate that can be used for electroconvulsive therapy. That is also an IV induction agent. Something about IV induction agent, propofol. Guys, remember, propofol is a milky white solution. It should be used within 6 hours. Otherwise, bacterial contamination. Why? Because it is made up of egg lecithin, glycerol, and soy. Egg lecithin, glycerol, and soy. It is the most painful IV induction agent, but the most important point of propofol is used as an IV induction agent of choice in what all conditions. For that, you have to remember propofol is used as an IV induction agent of choice for daycare surgery. When a patient is coming to you for a daycare surgery, will you put an endotracheal tube or LMA? If you put an endotracheal tube, that will cause sore throat. You don't want post-op complication for daycare surgery, so you will put an LMA. Hence, propofol is the IV induction agent of choice for LMA insertion. Next, when a patient is posted for daycare surgery, will you use inhalational agent? You will tell, oh, I will not use inhalational agent. I will only manage with IV agents. I am managing general anesthesia without inhalational agent. That is called as TIVA. Total intravenous anesthesia. The IV induction agent of choice that could be used is propofol. Apart from that, in daycare surgery, you don't want patient to develop any complications. What complications? He should not develop any rashes or any allergic reaction. For that, you have to remember propofol is having antipruritic property. Okay? You don't want the patient to develop vomiting, nausea. So propofol is having anti-emetic property. Very, very important anti-emetic property. Apart from that, your patient who's posted for daycare surgery is asking you, sir, I have heard that IV induction agents, when you are giving, it will cause malignant hypothermia or it will cause some liver problems. You tell them propofol is an IV induction agent of choice if the patient is having malignant hypothermia. So it is very safe in malignant hypothermia. It can be used safely in liver disorders. Okay? And it can be safely used in acute intermittent porphyria. So propofol is used as an IV induction agent of choice in all these conditions. Very, very, very important, guys. Next is sodium thiopentone. Sodium thiopentone is regarded as an ultra short acting barbiturate. Why it is regarded as an ultra short acting barbiturate? Reason kya hoga? Why? Because it is having rapid redistribution. You give sodium thiopentone and it gets rapidly redistributed. Where? Into the fat as well as muscle. Fat or adipose tissue and muscle, it gets rapidly redistributed. It is having anti-thyroid property. So it can be given in a patient who is having hyperthyroidism. It should be prepared in any fluid except the Ringer's lactate. But regarding sodium thiopentone, the questions that are asked are, what is the effect of sodium thiopentone on various systems? Regarding propofol, daycare surgery and all those MCQs you have to remember. Regarding thiopentone, you have to remember what are the effect of thiopentone on various systems. Various system means CNS, respiratory, cardiovascular, muscle and analgesia. Always remember, thiopentone is the best friend of CNS. Best friend of CNS means what? It is doing best things to the CNS, decreases the ICP, hence can be used in head injury as well as neurosurgery. Apart from that, if it is a best friend of CNS, it can be used in epileptic patients. Next, it can be used for narcoanalysis or truth test. But it is contraindicated in what, guys? It is contraindicated in acute intermittent porphyria. It is contraindicated in shock as well as ischemic heart disease. Why? Because it can cause hypotension and tachycardia. Very, very important. Okay. Remember, propofol also causes hypotension, but thio causes hypo and tachy. Propofol causes hypo and brady. Okay. Next is ketamine. Ketamine is usually called as a complete anesthetic agent. I told you it is a phencyclidine derivative and it is usually working on what receptors? It usually works as NMDA receptor blocker. NMDA receptor blocker. There is one more drug called as esketamine, which is a psychoactive drug which can be used as a rapid acting antidepressants. Now, regarding ketamine, what you need to remember is what is the effect of ketamine on various systems. Ketamine is opposite of thiopentone. Thiopentone was the best friend of CNS, enemy of others. Ketamine is the worst enemy of CNS. Ketamine is the worst enemy of CNS and best friend of other systems. As it is the best friend of other system means respiratory. It can be used as an IV induction agent of choice in bronchial asthma. Why? Because it is having a bronchodilatory effect. Next, ketamine can be used for, remember, it's a best friend of cardiovascular system. So ketamine increases the BP and pulse rate, hence can be used for as IV induction agent of choice in shock. You can use ketamine. Apart from that, ketamine can be used for cyanotic heart disease. Cyanotic heart disease. Cyanotic heart disease means tetralogy of Falley. You can use ketamine, but contraindicated in ischemic heart disease. Why? Because it is increasing the BP and pulse rate. Okay. Next, what is the effect of ketamine on CNS? Ketamine is the enemy of CNS. Yani it increases the intracranial pressure. Ketamine does kit with the CNS. As it increases the intracranial pressure, contraindicated in head injury and neurosurgery. Very, very important, guys. Head injury, neurosurgery. It increases the intraocular pressure, hence contraindicated in glaucoma patients. It causes epilepsy, hence contraindicated in epileptic patients. It causes hallucinations. Ketamine causes hallucinations, hence contraindicated in patients who are already having schizophrenia. Okay. Hallucinations, if they are caused by ketamine, then it can be easily managed with the help of midazolam. Midazolam can be given for management. Okay. Next, in alcoholics, you can use propofol. Okay. A 4-year-old boy is scheduled for elective inguinal hernia repair. He is anxious and refuses IV cannula. The anesthesiologist plans an inhalational induction while using a face mask. Okay? Using a face mask. Okay? Which inhalational agent is of choice in this patient? Enflurane, isoflurane, desflurane, and sevoflurane. Come on, guys. Child is not allowing you to put an IV cannula. If you want to induce the child or you make the patient unconscious, then you have to use what? What's the answer over here? Very good, guys. The answer is sevoflurane. Why? Because our sevoflurane is having what odor? Sweet odor. Okay? Sweet odor. Very, very important. Sevoflurane is stored in what vaporizer? Yellow color vaporizer. I told you Sevaiya, you have to remember. Sevaiya. Sevaiya are sweet and they are yellow in color. Okay? Next. But you also need to remember something about desflurane. Desflurane requires a special vaporizer. Vaporizer is a device that stores a liquid inhalational agent. As desflurane is having a low boiling point, it requires a special vaporizer. Very, very important. Tech 6 vaporizer or electronic vaporizer is required for desflurane. Now, regarding inhalational agents, guys, remember, inhalational agents usually work on two principles. What two principles? They work on MAC and blood gas partition coefficient. MAC indicates the potency of inhalational agent. Very, very important. But MAC and potency are always opposite. High MAC is equals to low potent and low MAC is equals to high potent. Low MAC is equals to what, guys? High potent. Okay. Blood gas coefficient indicates the speed of onset and recovery. Now, if someone is asking you most potent to least potent, he is basically asking you low MAC to high MAC. The mnemonic for it is what? HISD. You can write MHISD. M stands for methoxyflurane, which is having a low MAC value, but it is not used. That's why I'm writing HISD. H stands for halothane. I stands for isoflurane. S से sevoflurane and D से desflurane. ठीक है? HISD, if you remember in this direction, you will get low MAC to high MAC. But if someone is asking you, tell the inhalational agents which are having low blood gas to high blood gas coefficient. Remember, blood gas coefficient indicates the speed of onset and recovery. Low blood gas means speed onset. So low blood gas to high blood gas comes in the opposite direction. DSIH. DSIH. HISD ka mnemonics opposite will be DSIH. D stands for desflurane, S say sevoflurane, I say isoflurane, and H say halothane. Okay, that's regarding what gets, that's regarding the MAC values. Now something regarding the inhalational agents, right? Sevoflurane. Sevoflurane is the special inhalational agent used for induction as well as maintenance. Induction as well as maintenance, you can use sevoflurane. No other inhalational agent is used. Apart from sevo, halothane can also be used, okay? But sevo is commonly used. Sevo is used as an inhalational agent of choice in bronchial asthma, very, very important, bronchial asthma. Apart from that, it is used as an inhalational agent of choice for daycare surgery. It is inhalational agent of choice for children. It can be used in children, and it is an inhalational agent of choice for neurosurgery. It is avoided in renal patient. Why? Because I told you sevo can react, if you're using a closed circuit, it can react with soda lime to form compound A or olefin. Compound A or olefin. Okay. Next, halothane. If someone asks you about halothane, guys, what you need to remember is halothane, 4 heads of halothane. 4 heads of halothane. First head of halothane is what? Hyperthermia. What hyperthermia are we talking about, sir? We are talking about malignant hyperthermia. Halothane can cause malignant hyperthermia. Next, hepatitis. What hepatitis? On repeated exposure of halothane, halothane can cause immune-mediated hepatitis. That is also called as halothane-induced hepatitis. Next H of halothane is what, guys? Halothane can cause halothane is contraindicated in heart disease. It should never be given in heart disease. Why? Because halothane causes hypo and brady. Apart from that, halothane can cause arrhythmias. Why it can cause arrhythmias, mere bhai? It can cause arrhythmias. Why? Because it sensitizes the myocardium towards the catecholamines. Next, last is H of halothane is halothane has 2 maximum. What 2 maximum are we talking about? Maximum muscle relaxation and maximum bronchodilation. Maximum bronchodilation. Okay, that's regarding the halothane. Now, guys, this is a very, very important slide, guys. Patient having condition and what are the agents given. Okay, if the patient is having heart disease, what is the IV induction agents given for heart disease patient? Okay, so for that, the mnemonic that we need to remember is, everyone please listen over here. You have to remember, for any patient who's undergoing general anesthesia, this should be the sequence. I will give IV induction agents, then I will give muscle relaxant, then I will give inhalational agent. That should be the sequence. Then only the mnemonic will work. For heart disease, what's the mnemonic, guys? You have to remember, heart enjoys very deep inhalation. What does it mean? Heart enjoys. You have to just focus on what? E, the first thing of the mnemonic. Okay? So when I'm telling heart enjoys very deep inhalation, what is the IV induction agent of choice for heart disease patient? Ethambutol. Muscle relaxant is vecuronium. Inhalational agent is, guys, desflurane is the best inhalational agent, but most commonly we use what? Isoflurane. The reason, desflurane requires a vaporizer which is very costly. Okay. Next, asthma. For asthma, what you need to remember? Asthmatic kids always seek help. Okay. यानी कि what is the IV induction agent of choice for asthma? Ketamine. What is a muscle relaxant? Any muscle relaxant, but try to avoid giving benzyl isoquinoline. Why? Because they release histamine. Next, inhalational agent, guys. Remember, sevoflurane is the best inhalational agent. Second best inhalational agent is halothane. Okay? As halothane is increasing the airway, causing increase in the airway resistance, it is regarded as the second best inhalational agent. Okay? It can cause bronchodilation. Next, shock. If shock is there, then what's your answer, guys? Shock. Shock kills the patient directly and indirectly. Okay. So K stands for what? Again, for shock. The IV induction agent of choice is ketamine. Muscle relaxant of choice in shock is pancuronium. And again, inhalational agent of choice in shock, same like heart disease, desflurane. But most commonly we are using what? Most commonly we are using what? Isoflurane. Next, for daycare surgery, patient may sleep. ठीक है. Patient may sleep. Patient P stands for what? For daycare surgery, the IV induction agent of choice is propofol. Muscle relaxant of choice for daycare surgery is mevacurium. And inhalational agent of choice is sevoflurane. Next, neurosurgery. You have to remember, guys, for neurosurgery, neurosurgeons treat all safely insane. What does it mean? T stands for thiopentone is used as a IV induction agent of choice for neurosurgery. Any muscle relaxant could be given after giving thiopentone. And what is the inhalational agent that could be given in neurosurgery? Sivo is the best, and second best is what? Isoflurane. Remember, guys, this is very, very important slide that covers many MCQs, right? Next, a 55-year-old man is scheduled for elective abdominal surgery under general anesthesia. On pre-operative airway assessment, only hard palate is visible. When he opens his mouth, he protrudes its tongue. What is the patient's Mallampati classification? Come on, guys, class 1, 2, 3, and 4. What is this patient belonging to? Mallampati is one of the favorite topic they have been tested. Either they're asking on a video based or in this MCQ format. So remember, when a patient is opening his mouth, you are able to see all the structures clearly, means you can easily intubate the patient. Okay, Mallampati helps you to know the ease of intubation. If you are seeing all the structures, if you are seeing push structures clearly, remember what is push means? Push meaning what? When the patient is opening mouth, if you are able to see tonsillar pillars, if you are able to see the whole of uvula, if you are able to see the soft palate and hard palate, then that patient belongs to Mallampati class 1. Okay? Mallampati class 2 meaning what? When the patient opens his mouth, you are able to see part of tonsillar pillars, you are able to see uvula, but tip is not visible. Tip of uvula is not visible. Tip is not visible. Then you will see soft palate and you see hard palate. Then it becomes Mallampati class 2. Okay? Just you have to remember push is for class 1. Remove the P, it becomes USH class 2. Remove the U, it becomes, patient is opening his mouth, you are able to see the soft palate, you are able to see the hard palate. Means what, guys? Mallampati class 3. In Mallampati class 3, you might also be able to see the base of uvula. Body is not seen, tip is not seen, just base is seen. Mallampati class 4 meaning what? When a patient opens his mouth, you are able to see only the hard palate. That is Mallampati class 4. There is one more class called as Mallampati class 0. Come on, guys, what is Mallampati class 0? If you see all the structures of Mallampati class 1 plus, patient is opening mouth, you are able to see the tonsillar pillars, uvula, soft palate, hard palate, everything, plus tip of epiglottis visible, that is Mallampati class 0. Okay, so remember, this is class 1, class 2, class 3, and class 4. This is regarding Mallampati classification. After doing the pre-anesthetic checkup, you give a certificate to the patient that you are fit to undergo anesthesia. What is that certification called as, guys? Please tell me, what is the certification I'm talking about? Come on, everyone. Once PAC is done, you will give it a certificate to the patient. What is the certificate called as? ASA certification. American Society of Anesthesiology certification. In ASA, there is ASA grade 1, 2, 3, 4, 5, and 6. That we have to remember. Remember, guys, ASA 1 means what? Patient comes to my clinic and tell that, doctor, I don't have any problem, no pathology at all, I am posted for surgery. ASA classification usually depends upon what? It usually depends upon the systemic illness. If the patient is free from systemic illness, he belongs to which classification, guys? He belongs to ASA grade 1. Okay? ASA grade 2, when do you say? When the patient is having systemic illness. Okay? When the patient is having systemic illness, mild to moderate type of systemic illness, then ASA grade 2. Yani ki patient is coming to me and telling the doctor, I'm having hypertension, but it is under control, or he's a smoker or socially alcoholic. So he comes under ASA class 2. Patient having systemic illness which is under control or without any functional limitation. ASA class 3 meaning what? Patient is having systemic illness, uncontrolled diabetes, alcohol dependence, moderately reduced ejection fraction, or a very obese patient, or morbid obese patient, comes under ASA class 3. Yani ki patient having a systemic illness which is moderate to severe, ASA class 3. ASA class 4 means what? Patient having life-threatening systemic illness, such as patient is telling you he had a recent stroke or MI. That recent stroke or MI can pose death, pose threat to his life during surgery. So that comes under ASA class 4. ASA class 5 means moribund patient. Without surgery, the chances of survival are less. Okay? Ruptured abdominal aortic aneurysm comes under ASA class 5. ASA class 6 means brain dead patient. Brain dead patient. Guys, just look over here. Please just look over here. ASA classification. Class 1 meaning what? Patient comes to me and tells, doctor, I am totally healthy. Class 1. Yani ki no systemic illness. Class 2 meaning what? Patient comes to my clinic and tells, doctor, I am having mild to moderate systemic illness. Okay? That is class 2. Class 3 meaning what? Doctor, I am having moderate to severe systemic illness such as alcohol dependence is there, markedly reduced ejection fraction. Class 3. Class 4 meaning what? He comes to my clinic and doctor, he'll be telling, doctor, I'll be at risk of dying. Why he'll be at risk of dying? Why? Because he had recent stroke or recent MI. Recent stroke or recent MI. He comes under class 4. Class 5 means moribund patient. These patients won't come to your clinic. You are going in the ICU and you are seeing he's on ventilator. He's having multiple problems. Example, he is having ruptured abdominal aortic aneurysm. Without surgery, chances of survival are very less. Moribund patient comes under ASA class 5. Class 6 also. Again, he won't come to you. You go to the patient and you will see that there is a brain dead patient. For organ harvesting, you will look for this. Okay, so remember, this is the ASA classification, American Society of Anesthesiologists classification. Okay, guys, so these were the important things, guys, that we need to remember for anesthesia purpose. I hope the session was helpful. I hope you give your exam with full confidence without any problem and all. Don't think about any negative thought. Whatever you have studied, be confident in that. Okay, and just crack the exam with good marks and good numbers, guys. I hope that I see you in the other end. Right. Guys, remember, for daycare surgery, the best is mevacurium, but in the option, if it is given you, rocuronium plus sugammadex is available. Sugammadex is usually costly. It is not available that much in India. Hence, if rocuronium with sugammadex is given, then you can go for rocuronium with sugammadex can be given. Okay, but otherwise you need to remember, as sugammadex is not available abundantly in India, you have to remember that the mevacurium is commonly used for daycare surgery. Okay. Okay, guys. Okay, mere bhai, take care. Take care, everyone. Take care. Okay. Eat well, sleep well. I know these are the stressful days for you, but this time will pass. Okay. Keep yourself motivated in any which way, whatever kind of motivation you need, spiritual motivation or with any other motivation. Just keep yourself motivated in the last phase of the exam. Okay. Okay, guys. Take care. Take care. Okay. Bye. Okay, thank you.